Good afternoon, everybody. It is my great honor and pleasure to be invited to such an important meeting in Ukraine. Yeah, I'm supposed to talk about a Japanese CLC screening program, but I think many of you think that Japan is very advanced in endoscopy. I think it's correct. And you might also think that Japan is very much advanced in screening program for cancer too, but it's not true. I tell you why later, but anyway, I'd like to start my lecture. But before that, I'd like to briefly introduce myself. I was one of the members for Paris classification for many years ago, 18 years ago, maybe. And, it's not advanced. No, there seems some problem with the slides. No. Yes. Oh, okay. So I was one of the members for Paris classification. And I'm also one of the members of the Japan NBI expert team, and we have published a JNet classification several years ago. And I'm also the vice chairman for Japanese guideline for colorectal ESD EMR, and the latest version will appear next year, at the beginning of the next year. I was here 4 years ago to attend your meeting in Olimed. And I also gave a lecture about stomach cancer screening in Japan 4 years ago in Moscow. So, now, the slide shows the cancer incidence and mortality in Japan. And colorectal cancer is #1 in incidence, and about 130,000 people develop colorectal cancer yearly. And how about mortality? Colorectal cancer is the second place for mortality. And on that, colorectal cancer is #1 cause of death for female. How about the outside Japan? So Japan is one of the most, one of the countries with the high rate of mortality due to colorectal cancer, and Russia too, and maybe Ukraine. I can't see Ukraine very well, but maybe is associated high mortality rate from colorectal cancer. And this slide shows the change of colorectal cancer incidence and mortality in the most recent period over the last 10 years. You can recognize that in the United States, incidence and mortality have decreased significantly. And how about Japan? Yeah, it's starting to decrease. But how about Russia? Russia is still increasing in incidence and mortality in colorectal cancer. I don't have any data about Ukraine, but maybe Russia and Ukraine are similar in population, so maybe you might have the same situation here. It is surprising. In Czech Republic, the incidence and mortality have decreased a lot. I don't know why. What is the cause of that? But maybe they have a good screening program for that. And in women too, we have the same tendency. Although there was a lecture concerning the Poland, he said that the incidence and mortality are starting to decrease now, but maybe this data is can be a little bit old. Okay. So, as somebody else talked before, to suppress mortality from colorectal cancer, early detection and treatment of curable cancer is very important. So like this, I detect this lesion and removed it with ESD procedure. And then how to detect early cancer? We have a long history of screening program for gastric cancer, and this is the old program for us. Before 2015, annual barium study was recommended for the people over 40 years of age. So we use the barium study for screening for gastric cancer, and something is suspicious by barium study, and then EGD was recommended. How about colorectal cancer screening in Japan? We started screening program 1992, and annual 2-day fit test are recommended for the people over 40 years of age. And if the fecal cord blood is positive, either of barium enema, sigmoidoscopy plus barium enema, or colonoscopy are recommended. But nowadays, only colonoscopy are recommended virtually. But according to a rule, either of barium enema or sigmoidoscopy could be done for the people who was positive for FIT test. The slide shows the ease of screening program. You might be surprised that only 20% of invited people had FIT test, actually. So the acceptance rate is very low in Japan. You might be disappointed to see that. So, but it is the truth. Only 20% of invitees accept to have the FIT test. And 7.3% was FIT positive, and among them, only 65% of the people have the following examination, and 5.1% cases colorectal cancer was detected. It is equal to 0.24% of all the participants of the screening program. And CRC screening in Japan consists of based on three factors. One is population-based, community-based screening, and people are invited by a postcard to have the FIT test or invited by a general practitioner. And another is workplace-based. So they are invited to have the examination at their workplace. Usually in workplace, they have physical checkup every year. And when the people are over 40 years of age, they are invited to have FIT test. And FIT test is covered by the local government, but the following colonoscopy is covered partially by the social insurance. Not all the cost is covered by the government. And the third factor is opportunistic physical checkup. And this is not covered by social insurance. So they have to pay for the cost, but sometimes it is supported by the employer. So with these three factors, it is considered that about 40% of men and 30% of women are screened anyway with either of three factors. But I heard that in Netherlands, more women are willing to have the screening test, but in Japan, more men are willing to have the screening test. It is partially because more men are working at several companies, and they are invited by the company to have the FIT test. Oh. Oh, maybe I made a mistake. No, I pushed on this. Okay. So, and there are many problems associated with screening program in Japan. The biggest problem is low rate of participation, and second, low compliance to a further test when even when FIT positive. So only about 65% of the people who were positive for FIT are willing to have colonoscopy. And it's not only in Japan, but also worldwide. High rate of false positives can be the problem with FIT screening. And there are also false negatives existing. And there's a problem about limit of age. So we are starting the screening. We are starting the screening program at the age of 40, but it can be too early, and there's no limit for higher age. So in many countries, they stop screening at 75 or so, but there's no limit about old age in Japan. So let me talk about other screening tests. The following services are considered colorectal cancer screening services in the United States. They are approved by the healthcare system in the United States. Annual fecal occult blood test, and sigmoidoscopy, and screening colonoscopy every 10 years, and so on and so on. But the last line, Cologuard. What is Cologuard? Multi-target stool DNA test is now rather popular in the United States. Cologuard, it's a stool-based test which detects DNA mutation present in colorectal cancer cells and adenomatous polyps. And it is also detects blood in the stool by FIT. So it's a combination of genetic test and blood test. But it's not available in Japan yet. And according to the American data, Cologuard, screening interval is considered to be every 3 years, and sensitivity and specificity are rather high, nearly 90%. But cost of the FIT DNA, the Cologuard, is significantly more than just a FIT. And as you know, abnormal results will require follow-up colonoscopy. We should confirm the result with colonoscopy, of course. How about CTC, CT colonography? Yeah, it is beautiful, but diminutive or flat lesions can be missed by CT, and there can be a burden of radiation because it is CT. And bowel preparation can be a little bit stress for some patients. And of course, there is a need for endoscopic confirmation after abnormal results. And the biggest problem is workload on technician and film readers. So technicians must work on computer, and the film readers must read many pictures. And according to some data, the detection rate of LSTs, lateral sprain tumors, by CTC, especially non-granular type, was not acceptable. So LSTs can be very large, 3 centimeters, 4 centimeters, but in spite of their large size, they can be missed easily by CTC. How about a video capsule endoscopy? Yeah, even with capsule endoscopy, also diminutive or flat lesions can be missed. And the capsule itself is not invasive, but there can be some restriction on activity of the patient. And bowel preparation can be a big stress before capsule endoscopy. 5 liters, 6 liters of purgatives must be taken. And capsule endoscopy can be expensive, and there's a need for endoscopic confirmation when the results were abnormal, and there's also workload on film readers. As somebody else showed before, the American Multi-Society Task Force presented a ranking of colorectal cancer screening tests. And the colonoscopy every 10 years and annual fecal immunochemical tests are placed as number 1 for screening stool, and the CT colonography number 2. But capsule colonoscopy every 5 years rank is 3rd. It's not high ranked. So let's go back to the screening program for gastric cancer in Japan. So initially, our program was annual barium study, and for the people 40 years old or older. But we changed our program in 2016. So after that, people can choose between barium study and EGD. So people can choose. And the starting age was changed to 50 years, not 40 years of age, but now 50 years old. And the screen tests are recommended biannually, not every year. That is partially because we have less number of gastric cancer now. After the eradication of H. pylori, we have a smaller number of gastric cancer cases. So we changed the program a little bit, and we recommend EGD, not only barium study, for screening. And should we put colonoscopy as first-line screening test for screening program in Japan too? So the slide shows the yield of screening program. FIT can detect cancer in 0.17%. In contrast, colonoscopy can detect cancer in 1.58%. So the yield of screening can be higher in colonoscopy. But there are some issues to be discussed. Direct evidence proving that colonoscopy reduces mortality from colorectal cancer is lacking in Japan. And participation rate will be further lowered. Now, even with FIT tests, only 20-30% of people are accepting the screening test. If we put colonoscopy as the first-line screening test, maybe participation rate will be lowered. And how should we assure safety and quality? And we have limited medical resources, so lack of colonoscopists, and we don't have enough budget for that. And concerning the evidence proving that colonoscopy reduces mortality, and now there are some studies going on to prove that colonoscopy can be better or equal to FIT test as a screening test. And concerning the age limit, should we delay the starting age for colorectal cancer screening from 40 years to 50 years? Maybe yes, but now there's a problem that young onset colorectal cancer is increasing now globally, not only in Japan, but also in the United States and in Europe. I don't know why, but you must be careful about that. And when should we stop screening? As I said before, many countries, and especially in the United States, they consider stopping screening at the age of 75 if prior screening tests were negative. So maybe in Japan too, we should follow this tendency. And I once talked about quality assurance in colorectal cancer screening. I was invited to Korea and I was asked to talk about it. But we don't have any guideline in Japan concerning the quality assurance for colonoscopy. They have some guidelines in Europe and in the United States, but we don't have any such guideline in Japan. And how should we assure quality in colorectal cancer screening? So qualification of the examiner is very important. So, but how can we qualify the examiner? Years of experience, number of colonoscopies performed, or should we choose board qualified endoscopists for screening program? But these factors are not necessarily represent competence of the colonoscopist. So should we consider cecal intubation rate, time for intubation, withdrawal time, or adenoma detection rate? But there are no gold standard, and especially adenoma detection rate is very difficult to compare in different populations. Maybe we should use better scopes, better accessory devices, high definition, wide angle, third eye, CAP, COF, image enhancement, or even AI, artificial intelligence, for screening. And does image enhancement improve polyp detection? Until recently, it was reported that image enhancement does not significantly increase the adenoma detection rate. It was controversial. But according to the recent reports, maybe image enhancement can improve adenoma detection rate. But efficiency in terms of time and cost effectiveness are the main issues concerning image enhancement too. And now I'd like to talk briefly about lesions often overlooked in spite of their importance. Depressed lesion, laterally spreading tumors or LSTs, and cesar-associated adenoma polyp. Now it should be called the cesar-associated lesion according to the WHO criteria, but yeah, these three lesions can be overlooked very easily. Can you detect a lesion in this slide? With NBI and near focus maybe. So, yeah, slightly reddish area. And with NBI, maybe you can see the boundary better than white light. And with magnified view, the vessel pattern is regular at the periphery, but irregular at the center. We should call it JNET type 2B. So it can be invasive cancer. And with indiocarmin, you can see the lesion is clearly depressed. And the pit pattern with crystal violet staining and magnification, the pit pattern was very irregular. And according to the patient's request, it was removed by ESD procedure. We recommended surgery for that, but the patient refused to have surgery, so we performed ESD for this lesion. But the pathological report was revealed to be well-differentiated adenocarcinoma, invading deeply into the submucosal layer, and even the lymphatic vessel was involved. But still, the patient refused to have the surgery after this. How about this? Can you detect a lesion in this picture? The patient was referred to me for the resection of a protrusive polyp in the cecum, but this is transverse colon. Can you recognize something? With indiocarmin spraying, you can identify the very flat lesion, flat elevated lesion. The diameter was nearly 4 centimeters, 3.5 centimeter or 4 centimeter. I performed ESD for this case, and it was proven to be well-differentiated adenocarcinoma, intramucosal cancer. We call it intramucosal cancer in Japan. Maybe you call it a high-grade dysplasia. But anyway, it was a huge lesion. But such a lesion can be easily missed. How about cesar-associated adenoma polyp? I wrote a review article for digestive endoscopy this year. And cesar-associated lesions look like these. And endoscopic discriminators of cesar-associated polyp from hyperplastic polyp as proximal location, larger size, irregular shape, indistinctive border, cloud-like surface, mucus cap, and you can identify remnant debris. And they are characterized by dilated vessels and dilated crypts. let's go back. So dilated crypts with NVI you can identify, or with chroma endoscopy. And even with the white lights, you can identify some mucus covering over the lesion. So go back to the issue, how we can improve ADR. I talked about the scope and accessory devices, but we should focus on colonoscopies too. Maybe withdrawal time is important, and some guidelines recommend retroflexion in the ascending colon, not to miss the lesions behind the folds. But for me, the most important is knowledge on non-polypal lesion like lateral spreading tumors, depressed lesion, or accessorated lesion. So the knowledge of the colonoscopist is very important to not to miss adenoma or to improve ADR. So here's the summary of my talk. Colorectal cancer screening with colonoscopy in the United States looks successful. Japanese program with FIT may not be working well enough compared with the United States. And should we adopt colonoscopy as a first-line screening tool? But lack of medical resources can be a major issue. And who should be screened can be another issue. Maybe older people or younger. We should start screening program later, or should we stop screening at 75 years old or not? And maybe a combination of FIT and colonoscopy would be a better and practical solution. And quality of colonoscopies is very important. So such kind of seminars are very important for the education of the colonoscopist. And anyway, participation rates should be improved in the first place, especially in Japan. Only 20 or 30% of participation is not enough for screening. Thank you very much for your attention.